according to the World Health Organization, health is a presence of physical, psychological, social, economic, and spiritual well-being, not merely the absence of disease or infirmity. And so when we take that look at health, we realize that health is not just something that we get in our doctor's office, but it's also from our homes, our jobs, our schools, communities, places of worship, in short, where we live, work, learn, play, and pray. When we begin to address issues of health equity,
not advancing.
We begin to address issues of health equity. We find that health equity is the realization by all people of the highest attainable level of health. And so in addressing health equity, we really need to begin to look at all areas and conditions that people are impacted by, specifically those that impact socioeconomic community, disadvantaged communities, as well as other social justice issues. And so we need to really build our work around the framework of social determinants of health, and that's what we've attempted to do in PPH as well as in tobacco control and prevention program. So Healthy People 2020 has identified social determinants of health as creating social and physical environments that promote good health for all, as well as they've identified 4 overarching goals for the decade. And so they've outlined an action plan for addressing these social determinants of health, and some of the interventions that they've outlined include programs. I want to briefly cover social determinants of health. Next slide. Some of the social determinants of health are income, poverty, education, employment, housing, community, environment, and the place community. And so some of our work definitely within BPH covers all of these areas. Our work within tobacco control addresses some of them as well, and I'll get into some of them a little bit later. Healthy People 2020 identified this action plan to reach their goals, to reach the goals nationwide, and have identified the interventions of policies, programs, and information to reach the outcomes, the behavioral health and health equity outcomes that they have identified in their goals. We in tobacco control, we focus on policy as our main intervention of our work. And just to kind of give you a brief overview before I go into the policies, a brief overview of tobacco use in Los Angeles County. We have just under or just over actually 1 million smokers in Los Angeles County. 1 out of every 7 deaths is caused by cigarette smoking. And smoking costs $4.3 billion a year, including $2.3 billion in direct medical costs. More than 500,000 non-smoking adults and children are exposed to secondhand smoke. And smoking is related to the top 5 causes of death in Los Angeles County. In terms of prevalence in the county, we see that the Healthy People 2020 goal is 12%. And we've reached a prevalence rate of about 13.2% or 14% according to the state in terms of smoking in Los Angeles County. But so we've really achieved quite a bit in terms of decreasing smoking prevalence in the county, but we still have a long way to go. And then also you'll notice from this slide that there's great disparities according to the areas in Los Angeles County in terms of smoking prevalence. So when you look at service planning areas, or SPA, I'll refer to as SPA, service planning area 5, which is the west side of Los Angeles County, so it includes cities like Santa Monica, it includes cities like Culver City, Malibu. SPA 5, you have a very low smoking prevalence of a 9.7%, as well as SPA 3 at about 10.9%, although I think those numbers may be adjusted on some level. We'll talk about that later. But then you have high smoking prevalence in areas like Antelope Valley, SPA 1, service planning area 1, Palmdale and Lancaster. You have about a 15.6% smoking rate. And the metro area, which is mostly downtown or the main part of Los Angeles City, the smoking prevalence is 14.9, and then spot 7, which is the east part of Los Angeles, is a percentage of 14.4%. So in Tobacco Control and Prevention Program, our goal is to lower tobacco-related death, disease, and disability in Los Angeles County by reducing smoking prevalence and exposure to secondhand smoke, especially among vulnerable populations. And we do this, again, mostly through our work in policy. Our goal through our policy work is to change the social norm in communities. So we want to create social and legal climate where tobacco is less desirable, less acceptable, and less accessible. So we do this work through policy interventions with cities across Los Angeles County, and there are 86 that we work with, and Los Angeles County itself. Over the county, this slide is a lot of information, and I can't provide the slide to, or the handout to Dr. Friedman to pass out to everyone. But this really gives kind of an overview of the number of policies that have been passed in Los Angeles County and cities throughout the county. We have almost 150 policies that have been passed. And just to kind of break it down a little bit, you can't see all these numbers, but we really focus in about 3 areas. One is the area of youth access, and so that's related to our tobacco retail licensing. So we work with cities who are interested in adopting a tobacco retail license program to require a license for retailers to sell tobacco in their cities. So retailers must have a state license, but it's a one-time fee for a state license. But cities can require that retailers have a license to sell tobacco in their city. And then that comes with different restrictions as well as potential for fines if they're found to sell to youth, to minors. And so it really becomes an incentive for retailers to, to uphold the law in terms of selling to minors. So it's been demonstrated that a tobacco retail license does decrease youth access. Those cities that have them have seen lowered or dropped rates of youth access to tobacco. So that's one of our main areas. Our second area is smoke-free multi-unit housing, or policies related to multi-unit housing. To date, about 14 cities have adopted policies that prohibit smoking on different levels in multi-unit housing. So it can be in the levels of in units themselves, as well as patios and balconies, as well as common areas and different recreation areas of multi-unit housing. So about 14 cities, I believe, have adopted policies, including the cities of Compton, Huntington Park, Pasadena, South Pasadena, Santa Monica has a policy. So there are several cities that have policies, and they're at different stages of implementing those policies. And then the third area, the third major area that we work in is smoke-free outdoor areas, or comprehensive smoke-free outdoor areas. And that includes places like parks, beaches, outdoor dining, other establishments where children are, other areas where the public areas, cities have chosen to prohibit smoking in those areas as well. So you can see the number of cities that have smoke-free parks, smoke-free beaches, as well as comprehensive policies. Some of the cities even include transit stops, ATM lines, service lines, for prohibiting smoking. So again, they're at different stages in implementation, but we find that with some of these policies, usually they're self-enforcing. With signage, it makes it easier to ask someone to stop smoking if there's a sign in place to tell them that it's the law. And so through our work with these policies, the goal again is to change social norms. And so by decreasing places where people can smoke, by decreasing places where it's acceptable to smoke, you're changing the social norm in terms of smoking. And so back, many years ago, when it was acceptable to smoke on a plane, for example, the policy was put in place to prohibit smoking on planes. and that started changing the social norm. In California, we've been one of the leaders in terms of smoking in the workplace, or smoking in restaurants and bars. And so now it's really unusual if you go into a bar and see someone smoking. You would say, you know, that's a strange sight to see, and that's because the policy has been put in place to help to try to shift that social norm. And so while we've gained quite a bit of leeway in some of these efforts, we still have a long way to go. We're continuing to work with a lot of cities on these issues, as well as emerging products, which aren't emerging anymore, but e-cigarettes, for example, we've been doing quite a bit of work in the past 2 or 3 years around e-cigarettes on smoke-free areas. I'm going to hand it off to my colleague Cindy, who's going to share with you information about our work in tobacco-free champions.
Okay, I got to go fast. My comment I wanted to make is I tend to follow the blog. I like to hear what the kids are saying, what the community is saying. I guess the message of tobacco and not smoking has come across loud and clear. There was a blog on how to use heroin, and they said they would never use cigarettes if you're taking heroin. So I guess the message is getting across that it was amusing and interesting to see. Now, I was the project director for the Tobacco-Free Champions Initiative. And the focus of this initiative was to change organizational culture through policy, to reduce smoking prevalence and to reduce the exposure of people to secondhand smoke. The initiative itself started in November of 2013 and ended on September 2014. We had partnerships with the Smoking Cessation Leadership Center located out in San Francisco, and we were a part of the Community Transformation Grant, the Choose Health LA Tobacco-Free Living Objective. This objective said that we were to establish systems, procedures, and protocols to reduce exposure to secondhand smoke among vulnerable populations. Our target population that we wanted to work with was the behavioral health community. There were some very remarkable and compelling statistics that we saw. There was a smoking rate of over 40%, 2 times higher than what we were seeing in the general population. Of course, nicotine dependency rates were high, and it accounted for about 46%, or 200,000, out of 435 annual tobacco-related deaths. People that had addictions and mental health illnesses were responsible for consuming about 45% of all the cigarettes that were being purchased in the United States. So it's very, very compelling. Now, this schematic kind of shows our approach and what our intention was to do. And we wanted to integrate tobacco cessation into the care and treatment of inpatients and outpatients. And we were looking at organizations that were in LA County. We knew that we needed to have a tobacco-free environment policy, a robust tobacco cessation program, and we needed to make sure that every single patient that walked through that door had some sort of nicotine screening done and appropriate referrals made. Can you go back one second? So ultimately, with these 3 pieces in place, we were planning on seeing that there would be organizational culture change, less exposure to secondhand smoke, less people smoking. So this was a 9-month project. Organizations that applied were granted $25,000. It consisted of in-person orientation webinars, 3 in-person webinars, 3 skill-building workshops, 3 site visits, technical assistance that actually occurred on a daily basis, telephonically and in person. And these 2 organizations that worked with us had complete access to the subject matter experts, project specialists, and other resources. One of the things that we had to look at, and I'm kind of an organizational person to look at implementing strategy, was to look at what we knew already existed in the community. We knew that there was a lot of myths and challenges, and it was confirmed when I started working with these groups. We saw that there was a belief that clients could not quit smoking without jeopardizing their sobriety or maintaining stability and mental health. So, of course, this is not going to be on the radar screen. I wouldn't want to do it if I believed that, right? The smoking is the lesser of 2 evils. Again, dropping that priority way down. Patients and staff don't want to quit. Bottom line for the management, we're going to lose patients and we're going to lose money. Staff will leave if they can't smoke. There's turnover, will go up even higher. Some of the infrastructure challenges that we knew existed was that there's limited or no management staff support, limited or no existing policies and procedures, limited or no enforcement for any policies that were on the books, And what was interesting with some of the communities that I worked with was they didn't even know the policy was there until someone actually sat down and read through. Very nice policy, never enforced. Knowledge gaps, which serve to fuel the myth, to perpetuate the myths and beliefs that existed. So, at the very beginning, what we needed to do was to explore what the current state was at the organization, and that was to assess the commitment of the management, staff, and clients. We had to identify who the key decision makers were and determine which key decision maker would be able to take what we needed back to their executive board so we could get approval. We needed to identify data resources to provide best information. And our best data resources were the frontline clinical staff. So in terms of organization, we needed to get an organizational profile. We needed to know how big it was, whether each job classification were multitasking or single tasking. Am I running out of time?
You're out of time.
Out of time.
Conclusion, sorry, you strict schedule here.
All right, that's no problem. Yeah. The bottom line we found out, because we're now, I think, 9 months past our last, where we checked in with them. We are having some problems at the site right now. We're setting up meetings to go through and analyzing where they're at. I've already had a dialogue with one particular site, and they've been able to tell me where they think they need to work. We're meeting Tonya in the next week or two to develop a plan of action how we're going to get these organizations back on track.
Okay, thank you. Sorry, the rest of you, we'll take one question. You're doing great work. And stay up here. Let's one quick question. Go ahead.
You guys go into like these programs like foundation where the mothers and children, the mothers are smoking cigarettes, and they're telling them that it's okay. My daughter just had a baby, and she smokes cigarettes. So they're telling her that, oh, she was breastfeeding. I said, no, you can't. But they're telling her, are you guys going to these type of places to, they really need to be educated. Because they tell her it's okay for her to breastfeed her baby an hour after she has
A great question. Yeah, go ahead.
Yes, I was going to say, yes, we do work with different agencies. We have a coalition for tobacco-free LA County. And agencies are welcome to join that coalition. We don't have any active effort right now with agencies, but we're open to partner with any agency that is willing to take information, receive presentations about cessation and about